Good day to you. Now, another slight deviation from the norm, because today I had the pleasure of doing a wishbone walk. Now, what is that? Well, the Wishbone Foundation is a research foundation in New Zealand that does research into orthopaedics. Now, we'll all at some stage end up in the orthopaedic department, more likely as you age. And their prime focus normally is joint replacement. And that is where we're going to stay focused today. There are three surgeons in Southland that I know the names of and know what they look like. I think there may be a couple more that I perhaps don't know, but as you can probably imagine, I've spent a lot of time in Southland Hospital and I've been into the orthopaedics department multiple times. The surgeon who I spoke to very briefly, who referred me for a second opinion at the beginning of my knee replacement journey, was Pierre, and he is the surgeon that has organised this fundraiser today. And the surgeon then I was referred to, who ended up doing my total knee replacement, is Chuck Luca. Now, he is the surgeon who is doing the demo surgery in the university building, and they are using models throughout, so nothing is real, and it is a perfect way to show you what knee replacement surgery involves, but without any of the gore. And a third surgeon who I know of, but I'd never met, and I didn't realise I'd even spoken to him till afterwards, is Russell Fowler. Now, he, in one of the rooms I went into, actually showed me what instruments they use to do internal sutures. And he wasn't wearing a badge, he didn't introduce himself, it was all very understated. He asked me, did I have any questions? I said, well, I don't know what I don't know. What would you like to show me? And that's what he showed me. And afterwards, I realised that's who I was talking to. So that was really neat. Now, I know what Pierre looks like, and he was walking through at one point, and I offered him a chocolate from one of the free chocolate boxes. He never said anything either. He was not wearing a badge. Nothing was overstated. It was all very understated, and really it was an open the doors, have a look, and this is what we do. So the idea was, it was a self-guided tour of Southland Hospital's orthopaedic department, and that included the fracture clinic, where they showed you there was a couple of models of hip and knee replacements, and this is what they look like. Now, because it was self-guided, you walked around you were given a map, you walked around all the different departments, and when you got there was somebody demonstrating something on most occasions. Now, I was walking through a corridor and there was a table with these joint replacements on it, and nobody in the corridor knew what it was they were looking at. So I picked up the knee replacement and I was having a look at it, and somebody asked me, said something about knee replacement, hip replacement. So I ended up explaining the basics of it to the people that were standing around me. And then later I was asked, was I a physiotherapist or something, but yeah, that often happens. So yes, we went through the fracture clinic. I didn't stay there very long because that was just being plaster casted and that sort of thing. Through the physio department, I did not need to stay there very long because I've been there so many times. But the bit that was really interesting was when we went over to the university building, got to speak to some of the manufacturers of joint replacements, and then got to see a simulated surgery. So here is the knee replacement that I actually have. There were various different manufacturers, including Stryker, which is very well known in America, and Smith & Nephew, which is the type of knee that I've got. So this is the type of knee joint, replacement joint that I've got. Flipped over to the side is the kneecap, plastic surface underneath. The black part is the covering on the femur, your upper leg bone, and the silver and the white part is the tibia, your lower leg. However, before I had a knee replacement, I had an ACL reconstruction. Now, I found on a table a model of how they reconstruct an ACL. Now, in this model, the ACL is the piece of rope and the little tie things at the end is where the screws would be. When they took the ACL out to do my knee replacement, they couldn't get one of the screws out, so they left it there. So this is what an ACL reconstruction model looked like. In this model, the rope is the reconstructed ACL and the metal ends replicate the screws that hold it in place. Now, it was at this point that who I found out later was Russell Fowler, one of the surgeons, asked me what did I want to know about, and he showed me a device that helps them to do internal sutures. So he gave me a demonstration on a shoulder and was putting internal sutures into a shoulder, and they put it down a little tube, and then there's a little pair of scissors at the end, and they can all operate it all from outside. It's all really, really clever. And then there's various ways that they can pull the ends through and tie the ends and all of that sort of thing. Basically, how they do keyhole surgery. And I found it really fascinating. And he was talking about how advanced the technology has gotten over the years and that sort of thing. Well, I can tell you that. I can see that from just basically how they've changed how they do ACL reconstructions. So it was really interesting. But when I got to the Smith and Nephew table, I got talking to them because I know that my knee is a Smith and Nephew knee model. Now, the guy that spoke to me here asked me what I did so that he knew what type of medical language he could use. Turns out he was a biomechanical engineer. And I later found out that they are often involved in the actual surgery itself. Anyway, he was showing me the different types of knee prosthesis that go onto the joint to replace the joint. The joint is not actually replaced, it's the surfaces that are replaced. But if you just look at this picture, you'll see two different types of knee replacement. Now, I didn't even know any of this existed. I was so fascinated. One of them, you'll see there's a bar across the back, and the other one, there is not. Look at where those two fingers are pointing. Now, normally the cruciate ligament is removed and the piece that fits over, that sticks up in the bottom section of the knee replacement, is replacing the ACL. The PCL, ACL is anterior, PCL is posterior cruciate ligaments. They cross over in the middle of the joint. The PCL is usually left in place. But if you have got compromised PCL and ACL and need additional stability, Smith and Nephew, they tell me this, that none of the others do this, and I didn't see it on those tables. Smith and Nephew put the bar across the back of the prosthesis part that goes onto the femur, which gives you reverse stability and a resistance point at which it will stop, which helps to give you stability in the knee. So, he was talking about the different types of surfaces that the prosthesis has, and he was showing me from different angles the part that goes onto the femur, and how the Smith and Nephew guys make the surfaces different thicknesses to try and model the actual body. Whereas a lot of the others, now I can tell you this because I looked at one, it looks like, a shoe off a shelf. So it was really fascinating, and I was really fascinated to be able to talk to one of the actual manufacturers and actually discover and look at and touch and handle the actual knee part that was put into me, because I asked, could I have a look at it before they put the implant in, and they told me no. So now I have seen what it looks like. But the most exciting part of all was when I got to go upstairs and watch them simulate a knee replacement surgery. Now, panic not, because everything in this next video is all models. They're all mannequins and nothing is real, but they show you how a total knee replacement is actually done. The surgeon that is talking, because they're all wearing masks and gowns like they normally would, simulated surgery. The surgeon who is talking is the surgeon who actually did my knee replacement surgery. Now, this is a fantastic way for me to show you what they do for a total knee replacement without grossing you out. It also explains why I have, when I say that amputating my leg was less painful than doing a knee replacement, it'll explain to you why that was when you see the saws and hammers that he uses.
The hinge and put in a new hinge. We try to leave as much of the normal tissues there as we can. It's just we replace the surfaces that are worn out. So it's a bit like a retread on a tire.
So really the term knee replacement's a bit inaccurate.
Well, we are replacing the surface.
Yeah,
The
so
surfaces.
it's resurfacing more than...
Yeah. So here on our patient, we've opened the knee. The incision that we use is a big long one out the front, and we go right down to the bone, open things up, kind of clear things away from the edges of the joints, and then I use a drill to drill a hole down the shaft into the femur. And the femur is hollow, and it's got a lot of fat in it, but it's hollow. And so it'll allow me to take a rod that slides into the femur like this. And attached to the rod is this a cutting guide here. And it's at a fixed angle to the rod, usually about 6 degrees, because the end of the femur is typically 5 to 7 degrees at angle compared to the shaft. And so we average that typically, and we'll just put in a 6 degree. If someone has a lot of deformity, then we'll correct and try to make it more like your normal anatomy. But typically about 6 degrees. And so then we'll take we'll pin this in position, and we'll take the rod out. And once I've done that, with this pinned against the bone, I can cut like this with a saw to create a flat surface. So I use my little saw like this, and just run that down the surface here, keeping it flush to it. And that creates that flat end of the bone. And with that flat end of the bone, I can then measure how big it is front to back. And once I do that by setting this against the knuckles of the femur at the back, and then adjust this here so that it just touches the front of the femur here. And then with that, I can now drill these holes here and here. And there. And that, with those holes then, tell me where to put my my cutting guide for the next step. So just like that flat plate here allowed me to make this cut, when I put this against the cut end of the femur there, it tells me where to make this cut here, and one at the back, and then there's 2 angled cuts here and here. And what I've created is a reproducible surface of a particular depth. It has 5 cutting surfaces on it. You can see the 5 cut surfaces here that I've created. And that's particular for each size that we use. So, you know, there's various sizes of implants because we're not all the same dimension. And so once I've created those shapes, then I can trial my femur against the bone and make sure that it fits correctly. And if it looks like that's going well, then I can move on to the tibia. And with the tibia, what we do is we have this jig here that clamps to the ankle, and it then sits low. There we go. Yeah. Can I get this up? I don't think so. All right. Well, we'll leave this. So the goal of this jig, this normally would kind of I tap that into the bone at the top here. This finger should rest against normal cartilage, and that gives me the right height from the joint surface to make my cut on the tibia. So I pin this in place just like I did with the other block at the end of the femur, and then make my cut, and then I have a flat surface on the upper tibia here, and you can see that in the model. And then once I've got that flat surface, I trial various sizes of tibial implant. And the goal is to have it just inside the normal bone, because if I make it overhang, the tendons that are around the knee will rub against it. It'll be painful. So we just set it just inside the normal bone, and I can pin it in place. And there's a couple of little short pins that go into that, and they hold it to the bone while I do the rest of the work. And so the tibia has a peg that sits down into the bone, and I have to I have to drill to make a hole for that peg. So this little tower here sits in here, and I can use a drill to drill down into it. And then the fins that you can see on this, they're actually part of the normal tibia as well. I use a mallet to drive that down into the bone to create the space for the fins too. And then once I've done all that, I'm ready for the trial tibial component, which looks just like a real one, but it's not for implanting. And so I put that in, and then I can trial the different sizes of inserts. And so we have a bunch of different plastic pieces that will fit into this tibia. Some are thick and some are thin. And the reason for using thick or thin is because I want to make the ligaments on the side of the knee just tight enough that it keeps it from wobbling back and forth too much. If I over tighten it, you won't be able to straighten it out all the way, and it'll be too painful to move after surgery. So I just want just a hair of play back and forth to allow you to move it with the swelling that occurs after the operation. And that's your knee replacement.
So, what was slightly unique with my surgery, which apparently is just how Chuck does it, the pieces that he was showing you that he puts onto the bone to line up, to know how much to saw off and what angles and all of that sort of thing, all of those parts are all custom made for my knee, and they were based on MRI and x-rays of the joint before they did the surgery. So all of those pieces were just unique to my knee. Obviously, the prosthesis part that they put on is also is sort of custom fit, where you would think, but some of them are not. Some of them are just off-the-shelf parts, and they make your bone fit the part. In my surgery, they made a custom-made prosthesis to put onto the end of my bones based on the scans that they had done in the hospital beforehand. The reason that he does this is to speed up the recovery and reduce the amount of trauma in the joint, because I'm likely to need more. So my next question then was, which bits wear out fastest? Well, the plastic cap that he put in between that he was talking about as a spacer, that is normally what wears out fastest. Now, the plastic that he talked about, and I can't remember its name, a specific type of coated material that they use for that part, which has changed over the years. But as with any mechanical man-made part you put into a body, it wears, and your body has to do something with all those bits and bobs. And what tends to happen is the body tries to absorb them. So what they have to do over time is go out and clean that all out, take away all the filings and all that sort of thing, and tidy it all up. The first thing they will do is replace the cap. As you saw, there are lots of different thicknesses of caps. I'll just show you quickly here the tools table.
And then we kind of grind away a cup into the.
So they might increase the thickness of the cap, plastic cap that goes in first, and then I asked him what normally would happen next. Now, apparently there's various things that could happen next. It depends on how the part wore, whether it was wearing sideways or whether the Smith and Nephew guy was right and everything's kept more rigid with their parts, and that determines what goes on next. They can put spacers in between the bone and the metal part that they put in on the end, the new surface, to keep the gap in the joint the same, a metal spacer, which I didn't know about. Sometimes the prosthesis part works loose and they just need to tighten it. And then sometimes it's actually worn and they need to replace the part. Each time they have to replace a bone covering on either the top of the tibia or the end of the femur. They have the rod that goes into the bone marrow needs to be slightly longer. The reason, because I asked him this, the reason for that is that each time they take it out, there's a bit less good bone left. So each time they put it back, they've got to go further into the foundations to get a good foundation to secure the new prosthesis part onto. So that's why you would normally start with a piece that's quite short, like the pictures on the table, and then the rod that goes into the bone will get longer over time, the more times you have to have the thing replaced. I asked the Smith & Nephew guy about running and knee replacements, and he gave me a really good, very diplomatic answer. He said, now this is the sort of thing I've come to the conclusion with anyway. Some surgeons are like, hell no, and some are, yeah, do whatever you want. He said that you know that the part has got a finite shelf life, and he thought about 15 to 20 years. I asked him based on, you know, people in history, but obviously it's not set in stone. And if you are knowingly going into an exercise, knowing that you could wear the part out slightly faster and you might need a new one sooner, then why not? Equally, he also said, if he's a golfer, and if he had needed some major joint surgery at the age of 18, for example, yeah, hell, of course I'm going to go back to golf. But if he was in his 50s and was a golfer and needed a joint replacement, he might then find a different type of exercise that doesn't compromise his enjoyment. So it is still all up in the air, because will I run again or not? There's two factors going on here. Whether the knee will like it and whether the blade on the other side will behave itself. So who knows? But anyway, I thought it was a really, really interesting thing for them to do. I'm so pleased that they did. And I will leave some details on the end of this video if you want to donate to the Wishbone Foundation. I think that I was actually the only person that was there today that videoed his mock surgery, which is a real shame because it's such a good educational tool. So, as always, thank you for watching. And if there's anything you want to ask, then please do. But I think I've just about covered it all. They did give me some research, but I am aware that research provided by a particular company is going to be a little skewed. But what I might do actually is use what he's given me to head on to Google Scholar and see what I can actually find out about what they've said. Anyway, that is all for me today. Have a lovely afternoon, evening, or morning, or day, or night, whatever time it is for you.